Which vaccines would you avoid?
Colic, which that's a different conversation. I don't like that word. It doesn't really mean much.
You don't like the word colic? Interesting.
No, I don't. Yeah, I don't think it means
we should get into that.
I mean, truthfully, it was the worst one I ever saw. And I don't really want to admit this, but I had my doubts when they came in if I could help them because it was so bad. But at the same time, they're like, we've literally been everywhere.
All right, welcome back to What Can We Get Into? This week we have Dr. Collin Walding. Tell us about yourself.
My name's Dr. Collin Walding. I'm a pediatric and prenatal chiropractor up in Prosper, Texas. And we just focus on serving families and making sure kids and moms are healthy.
I love it. So I texted you a few weeks ago to bring you on, and I was like, I need somebody that's in pediatrics because it's not something that I specifically treat. Now I have kids running through here every now and then, but it's not my specialty by any means. Last night, I had somebody from back where I used to live in Louisville. He texted me and he was like, hey man, do you have any content on how to treat kids or like what to do with kids in chiropractic? And I go, not currently, but funny you ask. So I shot you a text. I was like, man, we kind of put this on the back burner. Can we do this? And so we got it done. But awesome, man. Went to school together. Obviously you sat behind me for like what felt like a decade and a half, but hopefully you were paying attention all those years.
Yeah, I tried my best. We had our good days and bad days with that. But,
So what got you into pediatrics?
Yeah, I get this question a lot, actually. So what got me into pediatrics was more of, I think, impact. So when Kara and I both went to school, we grew up being athletes. And I say being athletes, I use that term very loosely. We thought we were athletes. So we always thought we wanted to serve athletes. So we got into school, we started kind of seeing, I guess, more of the back end of like what it actually takes to see athletes and, all the, gizmos and gadgets and the soft tissue work and everything that went into it. And it just didn't really light us on fire. And, I always joke with athletes, I don't know if they're ever happy. They're always like, they can come in with 10 different things and you could fix 9 of them and they're still going to complain about the one thing.
Right.
But I just think on our like souls, it just didn't feel like, hey, this is who we're supposed to serve. And then as we got further into school, I say that probably around like try 3 or try 4, into that first year, we got the opportunity to go shadow a pediatric like in prenatal office. And it was such a shift for us, I think, because it was just looking at the impact that, you got to have on that family. And, something we talk about a lot in our practice is just like, if a child is struggling, it's not just the child, right? It's mom, dad, brother, sister, coach, teacher, whoever, right? It has a huge impact on their quality of life. So whenever we, number one, actually saw the results and how like this was changing a family's life and dynamic, it was kind of like, for me anyways, I was like, if you're telling me I can do that, like sign me up. So that was like the biggest, like, I guess, shift for us as to when we really shifted from like thinking that, hey, we wanted to do more athletes and stuff like that to like just being a pediatric and prenatal focused office was probably just the impact.
It's a huge shift, obviously, because the conditions you're dealing with is a complete 180 as well. And I was kind of looking through your website and seeing all the things that you treat. And I think one of the biggest, when I have the rare occasion that I have a kid in my office, it's always funny to hear the buzz in the waiting room of like, what kind of pain does that kid have? Like what kind of symptoms? And obviously you're not looking at things that way necessarily. How do you go about assessing a child?
So really going about assessing a child is just like, for us, it's always about connection, right? So sitting down with the family and just figuring out, hey, like what's going on right now? Right. What is this child dealing with? I would say really common things that we see. It kind of shifts between different age groups within the pediatric population. So newborn care is a really big deal in our office, right? So things that we're looking for there is really things around latching, feeding, motor milestone stuff, right? We break things down into gross motor milestones and into different kind of phases. So looking where we're at there, sleeping, digestion. So just all the kind of basic things. And the basic things that we always talk about are eating, sleeping, and pooping. Like, hey, it doesn't matter if you're 2 days old or 100 years old. Those are pretty important things. So a lot of our symptomology for newborns specifically will come around that. And then you start transitioning into, we'll call it the toddler phase, the 2, 3, 4, 5-year-old kiddos. Then you start looking more into like usually ear infections. You can say behavioral challenges, but usually still having issues with the sleep stuff, the digestion stuff, and everything like that. So really going about assessing that is just trying to figure out like, hey, kind of what part of their neurology is offline right now. So like when I'm just having a basic conversation with a parent, I'm really just trying to get a good idea of like, hey, like what's offline right now? What's not, what's going good? What's not going so good. And then from there, we use different kind of diagnostics. They're not even really diagnostics in our office, but we use a different objective assessment protocol in our office to really just start to pinpoint, hey, how much stress is actually on their neurology and on their nervous system. And then two, where's that at? So we can actually kind of formulate a plan of like, okay, this is what we want to do about this.
What's the most common milestone that you see is missed or delayed or not where you want it to be?
The newborn population. So we break things into different stuff. So we break things into motor 1, motor 2, and motor 3. So motor 1 is basically all things head control. So this is usually 0 to 4 months. So 0 to 4 months is basically all things head control. And the biggest, I guess, outputs that we're looking at there is, hey, are they actually able to perform tummy time? How long are they able to do this? But when I have a kid coming in with that stuff, I'm always like, we try to find a baseline for tummy time. We always trying to extend that as we get closer to 4 months. So we can accumulate usually around 45 minutes to an hour of tummy time throughout the day around 4 months so that we can transition into motor 2. Okay. So it's a lot of things around head control and motor 1. Then you have motor 2, which is more thoracic activation. So usually 4 to 7-ish months. So this is when kiddos should start rolling. They should start sitting assisted or independently. It's kind of all of that stuff. And then you get into motor 3, which is usually transitioning into crawling and then easing into walking and cruising.
You know what's interesting is I have a 2-year-old currently, and when my wife took him for either his 4 or 6 month visit, she came home and she was like, we're not doing enough tummy time. And as a chiropractor, I'm like, okay, that's important, but like, what is she telling you? She's like, he needs to be doing 90 minutes a day. Does that time increase from that 4 month mark, or what are you wanting to see time wise on tummy time?
Well, really time wise for me is what I want to see from 1 month to 4 months is I want to see that increase. So I always kind of give it to people as like a workout regimen, right? So when I have a kiddo that comes in and they're having a ton of issues with head control, probably having issues with latching and feeding and some of the other stuff there, is I want to say, okay, what I want you guys to do is go home and I want you to find a baseline of when you put them on for tummy time, how long can they take essentially before they're head bobbing, usually screaming and crying and all that stuff. And I want to say, okay, cool. This is a starting point right now. Okay. So what if it's 1 minute? Okay, cool. I want you to do that 10 times a day. Okay. And then from there, what I want you to do next week, I want you to make that 2 times or 2 minutes, 10 times a day. Right. So what I really want to see is progress moving forward. Okay. Yeah. So for me, it's not, I don't get super married to the number, like 45 minutes to an hour by the time we're 4 months is going to be in a really good, healthy place. What I really want to see, and it's different for every kiddo, right? Because we have preemies and stuff like that come in and they're just in a different place neurologically, even with growth and development, that we just have to kind of acknowledge where they're at there. But as long as we're seeing progress and that's starting to stretch out and they're getting stronger and they're moving through things. And really the big picture with motor milestones for us is everything needs to be in the right order. I don't get super caught up on timing of that. So if it's like, a lot of these apps and stuff nowadays are like, on this day, you should be doing this. Then moms come in and freak out. They're like, well, Joey's not rolling and the app says today that he's supposed to be doing that. It's like, well, look, we need to make sure that the foundation for all the gross motor stuff, and this is where people kind of, I think, miss the point a little bit, is all of your gross motor stuff is how your brain starts to grow and develop moving forward. Like that lays the foundation for the rest of these kids' lives. So I want to make sure that things are going in their proper order versus just getting super married to the time of which they do it. Now at the same time is that if you have a 12-month-old that comes in and they're not rolling or haven't done anything else, like, okay, now that's a problem, obviously. But just generally day to day, it's like we want to see progress throughout that stuff. As far as like, something example is tummy time, we want to see that time start to increase as we get closer to 4 months, as they should start to transition into the rolling and the more thoracic activation stuff. But it's really, order is just super important there versus timing.
In terms of baby sleep, it's always educated to make sure they're not spending too much time rotated one way or the other. Yeah. What's your opinion on that?
Man, I'm very passionate about this. I have a lot of thoughts on this. I see a lot of, I just finished up a 10-month cranial certification last year. So a big population of the newborns and stuff that I see right now are kiddos that do have issues, have a cranial distortion pattern, right? So 2 main ones that we look at is brachycephaly, which is going to be a posterior left or posterior right flat spot that usually comes from a head rotation preference, right? So if a kid loves left rotation, right? They have a left head rotation preference, meaning they're always spending time there. They're going to start developing a posterior left flat spot. Same thing with the right. And then the second big classification that you see there is plagiocephaly. So plagiocephaly is going to be more of just a posterior flat spot. A little bit more interesting to deal with because a lot of times these kids actually have the ability to go left and right. And I don't want to say that they're just lazy, but they need a lot of encouraging through the neurology and just more activity there. But the biggest thing that I speak to with parents, when they come in and I've got a 2-month-old or a 3-month-old, which is best case scenario of catching it that early. that has a flat spot somewhere, we'll call it a flat spot, is just really making sure that we're being active, right? So on top of the chiropractic work that we're doing, when we're at home, I'm like, hey, we need to make sure that we're encouraging the neurology to be going this way. We need to be super active with them. But the flip side is kids in general right now spend way too much time on their back. And it doesn't matter if it's sleeping. This is another pretty charged subject that I get into a lot in my office. In pretty much every other culture around the world, within 4 to 8 weeks, kids are sleeping on their bellies, which is a really big, that's actually the optimal position for their spine and their neurology as well. And we're also kind of led to believe that like SIDS, they're going to suffocate, right? All this stuff, which is just, I have my thoughts on it, I have my opinions on it, but the optimal position, and it's funny too, because I tell parents, I'll tell moms at 2 months old, I'm like, hey, you're probably going to think I'm crazy. And if it makes you more comfortable, wait until they're rolling, especially when they have a flat spot on their head. As soon as they can get to sleeping on their belly, I want you to start with naps. I know you're going to probably have some anxiety around this. So if you need to, sit there and stare at them while they're napping and get comfortable with it. But the more, I always say with head rotation stuff, number one, we have to go in and actually restore motion and function to these joint spaces so they can actually do that stuff. But number two, we need to encourage the neurology to be moving forward versus just like, okay, cool, we're doing this, so let's just go lay them down. Because what I always tell parents is like, hey, minutes matter throughout the day. So if I'm seeing your kid for 10 minutes and doing adjustment and everything is going great there, but they go home and they sleep on their back for 23 hours a day, then it's not helping things.
I'm totally on board with you on this. And I think that this transfers to adults. I don't necessarily know the data on that, but as chiropractors, we're taught that sleeping on your stomach is the worst thing ever. I mean, I don't know the adult data, but to me, it never made sense. Now, if you throw a huge pillow underneath your head and get all this extension, okay, maybe.
Yeah.
Do you have an opinion on adults sleeping on their stomach?
It's actually really funny. So I had a mom literally ask me, I think on Monday this week about that. Cause I was having that exact summer conversation that I was just having with you, with her. She was like, what about adults? I was like, honestly, I don't really know. I mean, like I was kind of telling her, I was like, I think that we were taught in school of like sleeping on your stomach is not optimal. But at the same time, I'm like, if it feels good, then
there's a lot of, I always like to look at things through an evolutionary lens. And I mean, we didn't traditionally sleep on mattresses evolutionarily and things like that. So, a patient always comes in and they got the tail between the legs, like, I'm a stomach sleeper. And I'm like, I'm actually not the guy that's going to slap you on the wrist for that. Yeah. And it's funny that you bring up the whole pediatric case of this, because I can remember when we were building out a registry for our son, and I don't know the name of the brand, but my wife was like, we need this $300 like breathable mattress. So if he sleeps face down, like he's not going to suffocate. Yeah. And I'm like, I promise you that like, maybe that's going to help you out like mentally, like you said. Yeah. But I'm like, we as humans, we never had this kind of stuff. And most of us survived it.
I think that there's so much that a lot of current stuff in the pediatric world, I think as far as recommendations, especially looking at something like SIDS, is a lot of the data goes back to, in my opinion, an outdated time. Yeah. And it's like they take something that happened twice and then they make a full protocol of rules that you can and can't do. But I think that people forget the innate intelligence of the body of like kids sleeping on their belly, right? That's why I tell parents, like, if it makes you feel more comfortable, then watch them nap, start with napping. So like you can get that, because like they're also indoctrinated and told a lot of other places of like, don't sleep them on their belly. They're for sure going to die if you do that.
No, so, with that being said, what's your opinion on swaddling and all these new wraps and Velcro straps and all that? Because that could potentially implicate this a little differently. Yeah. So for me, I think swaddles are, right. So there's a lot of different research on this. I'm not 100% sure how I feel about it, but a lot of times there's a startle reflex, right? And a lot of times they say that you need to be into a startle reflex to get into REM sleep as a newborn. And the swaddle actually diminishes that. Interesting. So I think one way or the other, for me, like my kind of loose recommendations that I have around swaddles and baby wearing and stuff. I love baby wearing. I really like baby wearing. I think that's super awesome. It's a really good position for them to just not be on their back and to be with mom. And I think it's just super awesome. Like as far as like going to the grocery store, wearing them around the house and stuff like that versus just going and laying them down and walking away. But swaddles are interesting. I think that when I start seeing kiddos and it kind of causing challenges is usually before they're about to start rolling, right? So they're swaddled from the time they're newborns until, we'll say 4 months. It could go longer. Usually it goes shorter than that. But some of the challenges I see around that time, and parents
actually, it's really cool when parents start to understand, like after we go through an educational process in our office of what they should be looking for. And they're like, you know what, I think I'm going to pull the swaddle, because they're kind of acting like they want to roll, but like they're freaking swaddled up all the time. I'm like, we have to let their neurology breathe, meaning like we have to let their neurology actually grow and have freedom, if you will. That's why I think tummy time is so important. Same thing. We have to encourage your neurology to grow and develop. And if we're not doing those things and we're not doing that, if you're swaddled all night in your thing and you want to roll over and you can't roll over because you want to be in an optimal position, but you can't, like, is there a perfect answer to that? No, I don't think so. But I think my opinion on it is more around like, we don't ever want to restrict them from being able to do what they're supposed to be doing.
Switching gears, the boppy seats, or the seats that you sit in that set the kids in a certain position so they can sit up, those traditionally have had, I mean, when we were growing up, they were a thing everywhere.
Yeah.
Nowadays, they're starting to go, What's your opinion on those? Yeah,
I get a lot of questions. I actually I had to make a video for my office about this, because I think it was like 6 months ago. I had like 5 questions in 1 week, and moms were looking at TikTok and they were like, hey, I saw this, that, and the other. And I was like, you know what? I don't have an opinion on it right now. So what I did is I went and looked at a bunch of them. They had told me that they heard that the boppy seats were bad for a kid's spine. Okay. After I looked into it and just kind of looked at everything and how they're doing that. So, I don't think there's any issue with actual like spine development, but I always go into making sure the toy is age appropriate, making sure the seat is age appropriate, making sure the toy is age appropriate. So in a boppy seat, should a 1-month-old be in a boppy seat? No, absolutely not. Their spine's not ready for an axial load. Okay. Should a 4-month-old be? Maybe, right? They're starting to transition into that kind of 4 to 6 month range where maybe they're sitting assisted, and that can actually be beneficial. But the second thing I go into with any of the seats and toys, I guess, if you will, but especially like the boppy seats, is just the time that they're there, right? So it's not appropriate for a kid to be sitting in that chair for 3 hours a day. That's not going to be beneficial for them. But if it's, hey, we spent 20 minutes there today while we were doing this, like, hey, that's probably fine, as long as they're in an age appropriate place, right? So for the boppy seat specifically, if they're between, we'll say 4 and 8 months or 5 and 8 months, it's probably appropriate, right? Meaning based on where they're at with their motor stuff. Now, if they're super lagging behind in their motor stuff and at 4 months, they're not even thinking about rolling, they're not having any thoracic stability or anything like that, it's probably not going to be appropriate for them. But just really making sure, like the 2 biggest thing with toys for me anyways is, 1, making sure that you're not doing something that's, their brain and nervous system isn't ready for. But number 2, just limiting the amount of time that's in there.
I love it. Latching. What percent is going to be at fault, or let me rephrase this. What percent of the problem with latching is from the mom versus the child?
I think it's a tough question. I think this is why we work with a lot of lactation consultants. We work with 2 main ones in our community that are just freaking epic. I think it could go either way. I think that latching and feeding issues, and then also reflux, there's so many components that you look at it too, right? Could it be mom? Could she have either a really fast letdown, a really poor letdown? Could she have poor supply? Could it be an actual anatomical thing, like with a mom's nipple? Yeah. Sure, absolutely. It could be any one of those things. And then from the baby standpoint, you start looking at oral ties, you start looking at palate shape, you start looking at tongue function, you start looking at latch reflex, you start looking at all these things of how they're able to actually feed, because sometimes it's both. Sometimes if a kid's got, a grade 4 upper lip tie, a super anterior tongue tie, and buccal ties, like, hey, that's probably going to be a really big deal there.
How come I didn't hear about all these ties when we were kids, or our parents didn't talk about them? What is the reason for this? Is it they weren't aware of them, or why?
I think so. I think it's become a really big deal now. And I think the reality behind it is you don't know what you don't know. And like for us, anyways, for me, I was kind of a throw some dirt on it, like figure it out kind of kid. I will say this though, it's funny because we have a lot of like grandparents that'll actually come in for a new patient exam, like with mom, and I'm going over all this stuff with them, and they're like, well, this wasn't a thing when I was a kid. Right. It's like, you guys also weren't looking for it. And, doing revisions has become a really big deal these days. And there's kind of 2 parts of that, as to why people do revisions and why they would or wouldn't want to. So there's a business aspect of it there as to why people are actually looking for it more. But I think there's a really awesome aspect of it as well of, I think like IBCLCs right now are becoming really big because they do such an awesome job, especially in private practice, of actually preventing any revision if needed, but also really guiding moms and helping moms with, if there is a latch issue. That's why if I have a baby that's coming with a latch issue and I go through the exam, like, hey, there's some stuff to work on here, but I really want you to see a lactation consultant, because there's so many things that they can do. It could be baby positioning. It could be how mom's actually getting a nipple into the mouth. I mean, it could be so many different things that they can like really really hone in on and at least optimize that feeding experience to potentially where you don't have to go have a revision done, to where, things are actually in a better place there.
Should a kid have a tongue tie revision if they're not having feeding issues?
So my opinion on oral ties is they're functional. I'm very, very big on this, because it's kind of a dichotomy, right? So if a kid has oral ties and you revise that oral tie at the wrong time, that kid could go into a feeding crisis. So it could actually go in the complete opposite direction that you're trying to go to. That's why body work and chiropractic care is absolutely so beneficial for these kids that do have oral ties, of making sure that we're actually getting this kid to the right place, that if they are going to have the revision, that at least after the revision, things are going to go in the right direction. But it's from a functional standpoint, right? So when we're going in, we're doing an oral exam and we're looking for, hey, is there a tongue tie, a lip tie? Are there buccal ties? Or a lot of people call them buccal ties. I'll call them buccal ties. Are these present? Okay, mom, how is feeding going right now? Hey, feeding is going great. They're getting everything down. They're gaining weight. There's no reflux. There's nothing like that. Because the reality is there could be a kid that has a grade 3 upper lip tie and an anterior tongue tie. It's very unlikely, but he could have both of those, but with feeding great and gaining weight and having no reflux and having no gas and none of those things. And you could have a kid that comes in with like a really low grade 1 upper lip tie that's just got all the things, right? That's have all the gas. It's got all the GI stuff going on. It's got reflux, and they're not gaining weight and they're not doing any of that stuff. So it's very situational. That's why I always say oral ties are functional. And if we need to revise an oral tie, it needs to be based on function, not just based on is it there or not.
Is it there or not? And I think that probably is where people are going to go wrong is take the kid to a dentist, take the kid somewhere, PCP. I don't know where they all hear this stuff, but I remember when I first got into practice, it was like once a month I was hearing somebody, I got to take my kid. We shared the same building with a pediatric dentist.
Oh yeah.
And a lot of them would come back and say, man, that was the most traumatic thing I think I've ever put my kid through.
Yeah. It's a lot, right? A lot of them have moved to lasers now, which I think is good. I've seen some pretty botched ones.
Really?
I've seen some pretty gnarly ones that did not go so well. But for us anyways, how we look at it is we have a community of practitioners that we work with. We have several pediatric dentists that we know and trust, that know and trust us and know how we approach things. I know how they approach things. So like when I send somebody somewhere, it's only because I've vetted them and I know that they're not just going to go in and revise a tongue tie because they can make $1,600 in 30 seconds doing it. So that's like, it is a big deal now though.
I think that's great.
Yeah.
What's the biggest misconception with kids getting adjusted?
That's going to hurt them. I always tell parents probably at least 3 or 4 times a week, right? Whenever I'm doing new patient exams on newborns, especially if it's a referral from a pediatrician or one of our community resources, especially if dad's there, I'm like, yeah, did you guys think your pediatrician was crazy? They told you to go bring your baby to a chiropractor. They're like, okay, dude. Yeah. Like that but the biggest thing for me is just, I think the biggest misconception is that chiropractic is only limited to back pain, which is false. And then number 2 is just like, is it going to be painful? But just understanding the difference between a, adult manual adjustment and then a pediatric adjustment and then a newborn adjustment, all those things look different. And even going into different techniques, there's different force applications for each one of those. So just once we kind of sit down with them and explain it, and it's kind of hard to explain. Like a lot of times I tell parents, like, I'm like, hey, pediatric chiropractic care and like looking at it is the most underwhelming thing, right? Sometimes babies are screaming and crying, but like, I think people are waiting for this big, huge, like crazy thing. And it's super gentle, it's safe, and it's specific. And then people are like, oh, like they have this big situation built up on their head of what it's going to be. And then I'm like, it's going to be super underwhelming. And they see the first adjustment, like, oh, like I feel okay. Yeah. So it's like, I think the biggest misconception is that like, and I get this question all the time of like, especially if a baby's crying while I'm adjusting them, even though half the time they're crying before I even touch them, of like, is it hurting them? And usually how I answer that question is like, hey, and I do see a lot of kids with like a really severe torticollis or like a really severe head rotation preference with a lot of birth trauma. I'm like, you know what? In that situation, it probably doesn't feel that great for them, but it's also like a necessary evil if we have to get through this stuff so that number 1, we can restore function there and actually get through our motor stuff like we're supposed to, but also prevent any flatheads or anything like that. Yeah, I think, big one is just that it's going to hurt them. Do
you primarily use your hands or instruments or what?
Yeah, I actually don't use instruments very often. It's always funny because when I see pictures of myself on like social media, like adjusting our office, like the activator tool is always sitting there. And so I'm always funny. I'm like, I literally never use that. Like I very rarely use that.
I would have thought you said the other way around, but
no, I I don't want to say I fully manually adjust newborns because that's not like the proper terminology, but I really just use my hands.
Choose your hands.
Yeah.
Do all kids need adjusted?
I would say absolutely yes. There's a lot of studies on this actually. I forget who it was. Someone did a study. I want to say it was Harvard. Did a study back it was pre-COVID, and it was a group of osteopaths. So how chiropractors and osteopaths are different is we basically have a different name for the same thing. Technically, chiropractors call it subluxation. Osteopaths call it segmental dysfunction. So a group of osteopaths did a study on 100 newborns that were born vaginally and healthy, right? Otherwise, really basically deemed a healthy birth, right? No intervention, no emergency C-section, no forceps, no episiotomies, like nothing like that. And they found that at least in the upper cervical spine, 99 out of 100 kids had segmental dysfunction. So I always tell parents, I'm like, there's at least a 99% chance that your kid needs to be checked.
That's interesting. And I think if you've ever witnessed a birth, you're going to understand why there could be an issue with this. What do you think the ideal position is for delivering a baby?
I think it's different for everybody. I think that truthfully, I think the baby's going to find the optimal positioning. If you look at it from a textbook, it's going to say LOA, right? Like that's going to be the optimal like delivery position for vaginal delivery. But in reality, you have to kind of look at things as two components, right? The baby has got to do its best to try to find space in there so it can grow and develop like it's supposed to. Because, going back to the thing that we just talked about of like, I just like to acknowledge that labor and delivery is super stressful, but two main components that, at least in my opinion, are the most overlooked things as to why kids are struggling so much is in utero positioning and then labor and delivery trauma. And in utero positioning, I always tell people like we never actually know the true kind of cost associated with that, like how much physical stress was actually induced on them, even if they were LOA, right? Even if they were in the most optimal positioning for that, but you have all the different positionings, right? So I would say obviously non-optimal would be like transverse, breech, frank breech, stuff like that. But what I always explain to people is each labor and delivery has its own pattern. Each kiddo is going through the birth canal differently. And a lot of people think that a C-section delivery doesn't have any physical trauma, which is absolutely false. That's the biggest thing ever. Like parents come in like, why do they have torticollis? They're a C-section. I'm like, well, let me tell you, right? So it's just, yeah. I just like to acknowledge that process is super stressful, but I don't know. I mean, like if you look at a textbook, obviously like LOA is going to be like the optimal positioning for a baby. But I think that babies are super smart. I think they're trying to get in position of what they feel is best and what's like actually going to help them get to where they need to be. How
do you feel about positioning for the mother during delivery itself?
Well, I think that has changed a lot over time as well. It's probably a better question for Kara. But just my research and stuff that I've done on it is, in hospitals, you're confined to a bed laying on your back. And I will say that's not optimal. And then we wonder why things are, the way that they are, we'll say within the L&D world right now. And there's a lot of good places. There's actually, I think it's really cool. There's actually a lot of hospitals now around here that are allowing moms to be, allowing them to be on, the yoga ball, allowing them to be on all fours.
I love that you say allowing them, like it's a right.
Which is wild, right? I mean, I think that's wild of like, you're telling me like, there's a lot of places there, they're like, you cannot get up. Yeah. You have to lay on your back and lay here. And that's just like, I can tell you that is not optimal.
And then once they hit you with that epidural as well, right?
Yeah. So I think, so there's a lot of misconceptions around that. And I think it's never, I think as a chiropractor anyways, it's never our place to try to get a mom to do something or anything like that. I think it's our job to empower them, just them to understand that, health is a freedom and it's your choice no matter what you want to do. Right. But, like epidurals, you can't feel your contractions. There's a really big increase in statistics that moms that do epidurals have more ripping and tearing. Tosin is another one that I feel pretty strongly about women getting induced. And the same thing, it's not my job to judge them or to say, hey, you shouldn't have done this or that and the other. But when you're getting induced, your contractions are significantly stronger, right, which is putting a lot more physical stress on the newborn going through that process.
Yeah, and I think that a lot of this stuff people don't figure out until they're actually in the delivery room. I mean, even me, with a decent amount of education in the medical field, walked into that room with, I knew everything that was about to happen. Yeah. And it really isn't that way unless you've done it before or you've educated yourself on it. So, and I think for me, treating primarily adults, I see a lot of women that have a lot of pain after a delivery on their back. And I think, even watching my wife, the amount of force that they're like, you're not pushing hard enough. And I'm like, my poor wife's about to pass out. Like, we need more. Like, no wonder the position you're in, laying on your back, all that hip flexion, all that external rotation, you're bearing down as hard as you can.
Yeah.
The discs just love that.
Yeah.
Not really.
What I always explain this to pregnant moms when I'm doing like a pregnant mom new patient exam. I'm like, labor and delivery, like it's like preparing for the biggest athletic event of your life.
Right.
Literally.
Yeah.
If you kind of look at the coordination there.
That leads me to a great point here is, how do you approach prenatal care?
Yeah. I mean, a big thing for us, we have a lot of goals for that, but I think big goals for us is how do we keep moms healthy during their pregnancy? And so many moms don't do anything. They're not proactive. They're not moving. They're not really doing anything. And then, they start having issues. It could be something as simple as back pain at 15 weeks. But then what happens whenever, your baby triples in size by the time you're 30, 32 weeks, and all the biomechanics of your body and your pelvis have changed and trying to shift around that, and they're just not having a good time. So one thing that we always go into is a stressed out mom is a stressed out baby. So for us, we look at like, how can we, one, get a mom moving better, feeling better, and functioning better, but how do we really set their body up for labor and delivery and also postpartum after that? Because there's just not enough emphasis on that. There's not enough in general, but specifically for pregnant moms to think that you can go through that much change that fast and do nothing proactive like exercise, chiropractic, whatever, pelvic floor therapy, and still have a perfect outcome. And it doesn't mean that if you do all these things that you're not, but the chances are a lot higher. So it's just putting into it is what you get out of it. So just really doing everything you can to optimize your body for literally the biggest athletic event of its life. But for us, our goals are really like, how do we set you up to have a healthy pregnancy so you can actually enjoy it? Because it should be a really special time. A lot of women come in and they're like, this is awful. I can't wait to have this baby right now. We want to, our favorite moms are the ones that we get them in early. We're able to support them throughout their pregnancy. They enjoy their pregnancy, and then they get to have their baby, and then they get to come back in for postpartum care. And just that whole, and it's both, it's the prenatal and the postpartum. But how we approach it is just kind of similar. It's same as everybody's. Want to connect with them, see what's going on, figure out what their birth plan is, and figure out how can we support them to their birth plan. Because it's not our job to tell them what it should be. It's our job to educate and empower. And if they have questions around like what they can and can't do around autonomy for their body, then we can answer that. But for us, it's just like, hey, what's your plan? And like, how can we help you get there?
How soon after delivery should a mom come back in to get treated?
It can be as soon as they want to. For us, I think how we approach it is you can get back in as soon as you want to, but what I do want you to do is I want you to spend some time at home. I want you to spend some time at home connecting with your baby, enjoying that, and at least take a couple of weeks to just really kind of settle back in. We have some moms that come back in literally 2 days after labor and delivery. And we have some moms that I would say the average for us is probably between like 3 and 5 weeks is when most moms come back in. There's not a right answer there, and there's not really a wrong answer. Care obviously looks different 2 days after labor and delivery as it does for 5.
Right.
And 5 weeks after delivery looks significantly different than it does at 3 months postpartum. So there's not really a right or wrong answer there. It's just I always tell moms, whenever you're ready, we'll be here.
What's the most common thing you see with pregnant moms?
Gosh, I mean, I would say the more classic stuff is just low back pain, sciatica, just challenges with their body changing so fast, right? I mean, you're literally from a hormone endocrine standpoint, your body is going nuts during that time, which is good. It's supposed to. And then you have the biomechanical changes of what happens when you actually start growing a baby and start adding, 15 to 20 to 25 pounds onto your frame. And every woman can take that differently. I think the biggest challenge is just coming that you're going through so much change so fast that your body's trying to keep up. It's just, your body always compensates. One thing I always say is we just got to figure out what's the cost associated with that. But, the classic stuff I think for pregnant moms is sleep, but it's usually sleep issues because they're so uncomfortable.
Yeah.
Right. And obviously you have to alter sleep position as a mom. You can't do certain things that you could otherwise if you're not pregnant. But just really, I think it's the biggest physical changes that are coming along with changing so fast.
How should a pregnant mom sleep?
Man, that's a good question. Not supposed to sleep on your back for too long, not supposed to sleep on your belly. So optimal positioning, and you're not supposed to spend too much time on your left side. So I think a lot of positioning for pregnant moms is how do you just find yourself comfortable with not cutting off blood supply or oxygen to your baby. But I have a lot of thoughts about that as well, and, about what's optimal, what's not. I think what's optimal is what you feel best doing. Obviously, sleeping on your back for too long, like there is a lot of risk with there. Really is a lot of risk with that.
Yeah.
But just trying to stay comfortable and stay moving, but just trying to, a lot of moms end up sleeping in like recliners and stuff like that, because that's just like kind of a happy medium there of not necessarily on your back, but elevated enough to get blood flow and everything like that down to baby. So I think for each pregnant mom it's different, but just find what's optimal, that's safe.
Yeah. I can remember my wife, there was like a day and time where she was like, I'm good. And then it hit and she was like, I cannot get comfortable.
Yeah.
Cause some women, they come in and they're like, this is the best I've ever slept. This is the best I've ever felt.
Yeah.
Those women are like made to pop out like 10 kids.
Yeah.
And then there's others, it's like the worst 40 weeks of their life, which sucks because it's obviously supposed to be beautiful. Pelvic floor. How important is it before? How important is it after delivery?
Man, this truly probably be a better question for like a pelvic floor therapist. But when I look at it, it's, pelvic floor is kind of, your nervous system is coordinating everything, but your pelvic floor and your pelvis together, and it works as a system, is what's performing everything. So I think it's extremely vitally important before, and I think it's just as important, if not more important. And there might be a pelvic floor PT that looks at this and maybe they'll flip flop that. I think they're both vitally important, but I think that when you look at preparing your body for labor and delivery, I think that work looks different than it does postpartum, right? So, prenatal care, if you're doing pelvic floor therapy of any kind, you're probably going to be focusing, hey, how do I prepare my body to actually deliver this baby? And then when we get done with delivery, we're going to be sitting there probably looking at more things of, hey, how do we get you back into a really healthy place? Because a lot of things that women do struggle with is like urinary leakage, pain with sex, things like that afterwards, which makes sense, right? A lot just happened there. But yeah, I think that they're both probably equally as important, but it just looks different for both.
It's interesting because this was something I don't feel like I remember learning much about in school. Mm-hmm. I don't feel like they talked about it much. I don't know. I may have just skipped that day or that week, but
I don't remember it either. I don't think they did.
And then I remember going out to Vegas for the first time, Parker Vegas, and they had a whole track on it, which I like a whole, you could do that for 3 days straight.
Wow.
Which I thought was interesting. And then I found a pelvic floor therapist in Kentucky when I was there. Mm-hmm. And there was kind of a sweet spot where if I was working on a postpartum mom and they were just kind of doing this sort of roller coaster, like they'd get better and they'd rescind, I was like, there's probably some weakness here. And a lot of times when I would send them out to the pelvic floor therapist, it was like light bulb turned on, strengthen that, and they got better, most of them, which I thought was awesome. What's the optimal amount of exercise for a pregnant mom?
Again, I think it could be different. I think in general, you should still be prioritizing at least 3 to 5 days of movement a week. I don't think it matters. It's the same thing. It just needs to look different. You need to be able to change as you go through different trimesters of being pregnant. And it just needs to look different, right? So whenever you're in your third trimester, just prioritizing movement, body weight, stuff like that, just being active and keeping blood flow going into your body and into your vital organ systems is going to be number one. Whereas, hey, when you're earlier on, you can probably still be doing more resistance training, more weights and stuff like that. Right. It's just super important to acknowledge that as your body changes, you need to really change and adapt with it. That's why I said this last year, Kara did a full 8-month, it's called Birth Fit certification of actually teaching moms how to move and how to exercise during different trimesters and how to actually change as you change so that you still, because it gets very discouraging, right? You get to 25 to 30 weeks for some moms, they're like, I can't do anything, right, which is false. There's other stuff going on there. They just need to understand that you can't do the same thing at week 25 and week 30 as you did at week 8. It just needs to look different. It's just having support there and learning how to do that. But 3 to 5 days of exercise, as long as you're doing that. And if you're getting 100 to 150 minutes a week, I would say probably pushing closer to 150 minutes a week, that's going to be more optimal. Every now and then on my Discover page will be a woman in her third trimester doing, like muscle ups or running a marathon. Yeah. Do you think that can be safe? Yeah. I mean, honestly, I think some women are built different, dude. We used to do CrossFit with this girl in Addison. And I'm not kidding. I swear 3 weeks after she had her baby, she was ripping muscle ups and she had a 6-pack again. And me and Kara were like, wow. But I think it's based on person. I don't want to go in safe or not safe, because I think if you're doing it and you're feeling good, as long as you're not, trying to go do 50-minute EMOM CrossFit workout and push your heart rate to close to max.
No
that's
Murphs
not
at
healthy.
38 weeks.
Yeah, right. So, I mean, be smart with that too. But if you can go on a light run and be in zone 2 to zone 3 cardio, then hey, I think that's perfectly fine.
So you would educate them to kind of go off of feel.
Yeah, absolutely.
Okay.
Go off of feel, like semi, obviously, but like obviously educating around like, hey, really just monitor your heart rate. Like you don't want to go into like a zone 4, zone 5 heart rate for 25 minutes during a workout right now. Like that's not going to be beneficial. That's going to be super stressful for you, but it's going to be super stressful for baby as well. Right. Yeah. Whereas, getting into something of a zone 2, zone 3 heart rate zone for exercise is going to be beneficial actually.
I love it. Scrolling through your website, you have an entire page on something called the perfect storm.
Oh yeah.
Tell me about this.
Yeah, so this is a big one. This is a really big thing in our office. And it's, I always say perfect storm, it's not a medical diagnosis. It's really just how do we track stress backwards from where a kid's at right now to where it started. And, the perfect storm is essentially a timeline. We need to figure out where they're at in that timeline right now. So where it starts for, definitely in my opinion, for 98% of kids is going to be in utero stress or labor and delivery trauma. Like, in my opinion, that is the most overlooked thing as to why kids are struggling as bad as they are these days, of just not acknowledging how much physical stress is induced on their neurology during that. Within the first phase of that is the newborn phase. Okay, so there's all these different phases throughout the perfect storm. And like I said, we really just need to identify where they're at and track backwards as to where it started. The big picture with perfect storm kids is they don't grow out of it. They just grow into a different season of stress, and then we call it something different. Okay, so phase 1, after labor and delivery and all that stuff, you look at the newborn phase. Typically what this looks like, it looks like the kiddo has latching, feeding issues, difficulty sleeping, reflux, could be excess tension through their body, so issues with head rotation, gross motor stuff, all the kind of classic newborn stuff that you would hear about. Colic, which that's a different conversation. I don't like that word. It doesn't really mean much.
You don't like the word colic? Interesting.
No, I don't. Yeah, I don't think
we should get into that.
Yeah. And then phase 2 is kind of just like usually the toddler phase. So usually these are kiddos that are 18 months to 2 years old to like 5 years old. So it's the ear infections, usually starting to get chronic immune like stuff kind of going on, usually probably still having issues with eating and sleeping and all that stuff and digestion. And then you get into more of the school age kiddo, 5, 7, 8, 9, 10 years old, somewhere in that range right there. And now all the behavioral stuff comes out. Now all the sensory processing stuff comes out, like ADHD, ADD, sensory processing disorder, autism, all that stuff really starts to kind of come out more than autism, usually more early on, usually around the age of 3 is when most kids get diagnosed. But it's really just tracking stress backwards and finding out, hey, when did this stress start and where are they at right now? And how do we need to go about figuring out what's going on and what do we need to do about it?
Autism is interesting to me.
Yeah.
1970, 1 in 2,000 diagnosis.
Mm-hmm. Yeah.
1990, 1 in 1,000 diagnosis.
Yeah.
Now 1 in 54 is the most current stat I've seen.
Yeah. I thought it was like 1 in 48.
1 in 48?
Might be. I don't know. I haven't looked at it in a while.
Is this a bias of now we know what we're looking for? Because I can remember when I was younger, there were certain, kids with special needs that didn't fit in a category. And I understand that might be the catch-all nowadays. Why do you think that diagnosis has quite literally gone up? I don't even know the percentage on that. 100 times.
I mean, an unbelievable amount. I think there's a lot of factors that are coming into play. Number one, people say if you test for it more, you find it more. I'm like, okay, but at the same time, I kind of feel the way as you did is you probably can't go to the grocery store now and walk around. If you walk around to every single parent in that grocery store, there's probably 5 that have a kid with autism, like literally, which is absolutely wild. I can tell you right now, growing up just between you and I, that wasn't the case.
No.
Right. So I would say that, hey, if you test for it more, you find it more. Sure. But I also think it is significantly more prevalent right now than it ever has been. Obviously, a very emotionally charged subject would be talking about, immunizations and a link there or not a link or anything like that. I think there's a lot of underlying stuff and there's my philosophy on it has changed a lot from school till right now because I've had so much of it walk through my door that people said, this isn't how autism happens. And then you talk to a parent about a kiddo that was fully functioning, a 2-year-old, we'll use a 2-year-old kid as an example, that was everywhere they should be on their motor stuff. They were verbal. They were working on being potty trained. They were in a really good spot. And then, an event occurred and Next thing you know, the kid's crawling backwards. He has no control of his bowel and he's nonverbal.
And by an event occurred.
Yeah.
You know, my wife a month ago was at some sort of park with my son. Mm-hmm. She's like 2-year-old there, clearly had some autistic sort of symptoms and behaviors. Mom told my wife that kid was perfectly normal, got the 2-year vaccines.
Yeah.
How often do you see that?
More than I ever thought I would. Unbelievable. People ask me this all the time. Like when we first, you open your practice doors and, obviously you have to build your practice to start seeing more people and everything. It comes through our office way more than I thought it ever would. And there's a lot of components to it. I think if you really want to dive into different things, I think that autism is potentially, I think it's opportunistic in a sense of, I think you take a kid that's so freaking stressed out, the neurology is so stressed out, their bucket is so full and they're not in a good place to receive a new stressor to their body in the form of a vaccine or anything like that. And it absolutely tanks their neurology. And I think that, and especially in the developmental phases of when all this stuff is happening, I think that autism is super opportunistic, and people can agree with this or disagree with this, but my opinion is based on that because of everything that I've seen in my office and just speaking with so many parents, more than I ever thought that I would on the subject. And just, it's one of those things. It's like, when do you start paying attention to it? Because it's like, it comes through your door so much. And I've had literally hundreds of conversations now with parents with kiddos with autism, and the amount of overlap and similarities between what happened and when it started, you could hear this conversation. You could say, that's not true. Like, this is bullcrap. They're just, sitting here saying that vaccines cause autism. And I'm really not saying that. But when it comes in, it slaps you in the face 200 times. At what point do you start to pay attention to it?
Which vaccines would you avoid?
I don't know. I really haven't got too much into that. I've done a lot of research on different ones. The really big popular ones that are kind of up right now is like MMR. MMR is probably the biggest one that people look at. I think that the biggest thing that parents need to do is their research on different vaccines, because I don't necessarily know if it's just one. I think it's the accumulation of all of them. And I think it's doing them all at once. It's too much for the body. And when you have a kid that's super stressed out, so I say it's opportunistic, and you add all that to their body, it's a lot for their body to process and work through. And if they're not in a good place to receive that, then they're not going to, and then you're going to be in a bad situation.
I just saw a video literally yesterday about a doctor talking about the vitamin K that you get right after birth. Yeah. Saying, don't do it. It's not a good idea. To be honest with you, I thought it was deemed pretty safe. It was one that I wasn't really worried about. What are your thoughts on that?
Yeah. To my knowledge and a lot of the research, I have done a lot of research on it. It's still got a black box, right? So it's not a vitamin K shot. I've seen a lot of different stuff online about what it is and what it isn't. What I do know is that it's not specifically a vitamin K shot. There are several other things in there.
Really?
As to what's
you said something about a black box. What do you mean by that?
So vaccines that are basically anything that is not like natural, like, if you go get a B12 shot at a, I don't know, esthetician clinic or something like that. Yeah. That's not a black box label. So like black box labels are basically an actual either attenuated or non-attenuated like vaccine. So you're actually looking at some form of like a live culture there, to some sense of where I'm not a vaccine expert or anything like that, but to my knowledge of it and a lot of the research that I've done, what I do know is that the vitamin K shot is not just a vitamin K shot. So I think there's a lot of myth behind that as to like, it's just a vitamin K shot. And the reality is it's not just a vitamin. I know that for a fact that it's not just a vitamin K shot. So same thing. I encourage parents, say, hey, you just need to do your research. I think this is why finding a good pediatrician is super important. I think finding a good pediatrician before you have a baby is super important because you can ask them these questions. And like I said, it's technically out of my scope of practice to educate on vaccines as a whole, as far as like when somebody comes into our office, like, hey, should I get this vaccine? Like, I can't tell you one way or the other. You need to do your research, but you really need to find a pediatrician or someone on your health team that will at least educate you on it. Because the problem is right now within that whole situation, whether it's a vitamin K shot or vaccines or anything like that, is people are going into their, I'll say, more general pediatric offices, and they're getting spoken down to, they're being belittled, and they're being kicked out of practices.
I've heard it.
Because they literally won't follow the insurance's schedule of getting all the vaccines. And then if they don't do that, the pediatrician doesn't get paid. So that's a joke. That's not patient-centered care at all. So you need to find a pediatrician that will actually answer your questions, that will educate you and empower you and hear you, and also see where your kid's at to see, hey, are they actually a candidate? If you guys do want to do this, that's perfectly fine, but we need to make sure that the timing is right. That's why we work with a couple different pediatricians in the area, really only 2, and they're super amazing because they educate parents, they empower them. And I can't tell you how many times that parents have gone and say, hey, we do want to vaccinate, and the pediatricians will say, hey, you know what, I think that's perfectly fine, but why don't we wait till they're after a year old? Because there's a couple of things going on right now that I just don't think it'd be a good time. So why don't we wait till after a year old? That's patient-centered care. Following off of the schedule for insurance, that's not patient-centered care. Yeah.
Last time I checked, the insurance company does not care if you're healthy or not.
They do not. They probably don't want you healthy.
They don't. I'm going to rapid fire some things at you.
Okay.
Most people are going to think of a couple of things when they think about babies or kids in chiropractic care. One of them being ear infections. Mm-hmm. What are you going to do for that?
Ear infections is usually going to be an upper cervical primary issue, right? So whenever kids are younger, eustachian tubes, usually it's definitely like 2 to 3 years old, and in babies as well, eustachian tubes are going to be a lot more horizontal than they are vertical. As we get older, they're going to drop more vertical. So this usually becomes a pretty simple brain communication things to local systems up through here, right? So there's a muscle on the outside of your eustachian tubes called the tensor veli palatini, or we call it TVP for short, because that's a freaking nightmare to say that. So really looking at proper communication from the brain to these vital organ systems. And it's I think ear infections are the most miscommunicated things ever. Like they're super straightforward, super easy to I say super easy to deal with. There's different tricky cases within that. But as far as your approach moving forward to that is, number one, you look at it from a chiropractic standpoint is, hey, it's usually an upper cervical related problem. Secondary to that, you need to really look at the relationship between the cranium and the sacrum and how your brain is creating CSF and pumping that from your cranium to your sacrum. So those are 2 kind of primary things of what we look at and focus on.
The next one would be GI. Mm-hmm. Whether it be kids pooping too much, kids not pooping at all. What are you doing for that?
Similar systems, actually. So there's 2 components that I look at for anything GI related, depending on the scans and stuff that we use in our office. But number 1 to the very tip top, this is more of just outward, coordination from your brain to your vital organ systems, which is looking at the vagus nerve, right? Your gut-brain connection. A lot of people listening to this may have heard of the gut-brain connection. It's literally the vagus nerve. So this is what lowers heart rate, lowers breath rate, and basically stimulates GI motility. It also has a lot of other stuff going on with the vagus nerve. You could go way in depth on this. But yeah, upper cervical spine, big time for that. And then really looking into the pelvis, really looking like either like TL area, like T12, L1, or really going down into the sacrum, looking at that parasympathetic plexus down the sacrum.
How much are you using a biomechanical approach? Hey, this joint is restricted. They don't have the adequate segmental function of this versus the symptoms that the kid's coming in with. Ear infection, are you taking that and going, I'm going to the upper cervical spine? Or are you going, like, how do you approach that from what to treat if maybe the segments are moving great, but they still have ear infections?
Yeah, we use scans in our office.
Okay.
So they're called CLA Insight scans. So it's really a 3-part scanning system. For the age 5 and under, or 4 and under, we only do 2 of the 3 scans. So the goal with these scans is to figure out how much stress is on your autonomic nervous system. So actually looking at the balance between sympathetic and parasympathetic, which is really, really big as we move forward. I always say HRV scan, that first one that we always do on kiddos, is always the king that we answer to, because depending on where they're at there, it's going to figure out, hey, do we need to, what levers do we need to pull, right? If a kid's way stuck over here and they're sympathetic, like way overstressed, then I don't necessarily want to adjust areas of the neurospinal system that are going to pull that more that way. So I really want to focus on adjusting the parasympathetics. So that's number 1. And then number 2 is getting a scan that actually identifies where exactly throughout the neurology it's expressing stress and dysfunction. So that's why I always tell parents, like, I really like scans in our office because it takes me out of it and it shows me that it's just,
objective.
This is exactly what your son's body or your daughter's body is telling us. And it gives us a really good idea of how we need to approach it from a technique standpoint, but also where we need to go. And also within that, what do we need to prioritize throughout that?
Heart rate variability is awesome. It's something I dove into when we were in chiropractic school because, that's the advent of all the fitness wearables and things like that. And it's pretty interesting if you've never studied it on yourself is, look at it. If you've been sick, if you've been stressed out, if something happened, you will see that number plummet, right? How are you tracking that on kids?
Like how do we actually get the measurement?
How do you scan it?
So the tool that's through CLA, it comes in a little box. It's an HRV scan. So there's actually a little plug that plugs into the side of it, and it collects it via the ear.
The ear, okay.
Right? So you actually have pulse and everything through that. HRV as a whole is based on 3 things, though. So it's skin temperature, skin conductance, and then heart rate. Right. So question that we always get around HRV, especially in the pediatric population, is like, hey, if they're nervous, is it going to screw this whole thing up? Well, not necessarily, because there's still 2 other objective findings there with skin temperature and skin conductance are not going to be affected. Those are more long-term chronic issues. Whereas if they're in an acute stress situation, is their heart rate going to be elevated? Yeah, sure. But it's not going to tank the whole scan. But yeah, it's always those 3 things.
What do you want to see in terms of a normal range for a kid?
So I look at it differently. So, all the scans in our office actually generate a score. I don't really care that much about the score. Whereas like I wear a Whoop, right? So Whoops and Oura rings and stuff like that's going to generate you a score, right? Like the higher, the better. And it's still the same thing. Our scans are out of 100. So usually the higher, the better, the more regulated, the more optimized that is. But for me, how it plots it out, it basically plots it out in a box. In the middle, at the very top middle, is going to be like the optimal zone, right? We call it zone 5. And then on this left-hand side, it's going to be show your sympathetic balance. On this right-hand side, it's going to give you parasympathetic. I want to see where that, and it's going to plot you a point somewhere on that, right? So you have zone 1, zone 2, zone 3, zone 4, and then zone 5, which zone 5 is optimal. And there's a y-axis too, which is autonomic activity, which I always say is like gas in the tank. So we really want to see is your gas tank is high and full, meaning your body has a lot of adaptability to these different things, as well as being balanced between both sympathetic and parasympathetic.
Do you track that every visit?
No, so we do it every 12 visits. So the scans are designed, so it's basically on day one exam. What we're going to do is we're going to collect that information, and then we get going into a care plan. It's every 12 visits into the care plan that we're actually going to reassess that.
And how quickly do you think that number changes? I mean, are you seeing it change pretty rapidly on 12 visits?
It depends on what's going on. Usually no. I mean, I always say HRV is the thing that drags behind, right? Because there's so much chronicity that goes into why you are where you're at.
Right.
That in 12 visits, which doesn't take very long to get somebody through 12 visits into a care plan, it can change. The biggest thing I like to look at is it moving in the right direction. So after 12 visits, I most certainly don't expect, depending on where they started at, right? If I give a person a 12 visit care plan, then yeah, I'm expecting for that to be in a really optimal place by the end of that. But that's I don't do that very often for kids. They're usually longer than that. Sure. But by the end of it, I want to see it in a good place. But I really just want to see it as we go throughout to continue to increase and get back to optimal.
That's interesting. I just had a patient today asking me about the vagus nerve and how they can stimulate it and how they can do it themselves and things like that, like pressing on your eyelids, diaphragmatic breathing, things like that. But it's kind of funny that we're talking about this because I just talked to a patient about it today. So we talked about ear infections. We talked about GI function. I'll save the best for last. You said you hate the word colic. Let's dive into that. What's your beef with colic?
Well, my beef with colic is I think it's a way for providers to get out of actually providing care to somebody. It's a way for them to say, "Oh, it's colic. I don't know.
Do you remember what Dr. Marty Hall used to call those diagnoses?
I don't, but I really want to hear it because I love Marty Hall.
He used to call them garbage can diagnosis.
Yeah, that's exactly right.
He said that shin splints wasn't real. And that was a garbage can diagnosis. Basically anything that just doesn't fit in another category. Yeah. I digress. Go ahead.
Yeah. He also said TOS was that. I remember he got in trouble, which I love. He said that.
TOS was fake.
Yeah. Love it. Love that guy. Colic doesn't mean anything, right? What colic is, it's an excuse for kids being uncomfortable. What colic means is kids are uncomfortable. So we need to figure out why they're uncomfortable. Most kids that do have colic, they absolutely have latching and feeding issues. They absolutely have reflux or something along that GI, and they usually have excessive gas or constipation, right? So we need to sit here and figure out what's actually going, or they're not sleeping too, right? So it's usually, or 1 and 2 lead to number 3 of not sleeping. So it's usually a whole host of different things going on. So when people come in, like, I think they're colic, which also I don't understand people's terminology of colic. Like, is it a thing or is it a diagnosis? But colic means uncomfortable. So when we see a kiddo that has colic, they're uncomfortable. We need to figure out why they're uncomfortable versus just saying they're miserable and they're crying. If you look at like the, Webster's dictionary, definition of colic, it's crying for an excess of 3+ hours a day. It doesn't mean anything.
How much of that do you think is related to reflux?
The reflux is tricky. I think reflux is a really big one. There's different forms of reflux as well. You have GERD, you have general reflux as a newborn, you have like more projectile reflux, and then you have silent reflux. This is one conversation I have a lot with parents. Is reflux is one of the most tricky things to deal with in newborns, and especially if if you're formula feeding a newborn, because there's 35 different things that could be causing reflux in your kid. It could absolutely be oral ties. It could be absolutely be non-optimal positioning. It could absolutely be stress in your kid's nervous system. It could absolutely be the nipple on your bottle. It could very, very most certainly be the formula that you're using that smells terrible and has corn syrup as its first ingredient, right? There's a lot of different factors to reflux. And yeah, when you're having reflux all the time and your freaking esophagus is stripped of all its mucus because of all the acid from your stomach, you probably don't feel great.
So all these formulas are terrible. How do you pick a good formula?
There's a lot of good formulas out there, but there's not ever going to be one that matches to breast milk. I think just looking through the ingredients and seeing where they're made, and different kids have potentially different allergies. Some kids could have a dairy allergy, so you want to make sure that you're looking for what different proteins are in that. Is it dairy? Is it non-dairy? Some of the, I don't want to say vegan formulas, but cow's milk protein formulas also have a bunch of other just junk in it, right? So me and Kara were at Costco like 3 or 4 years ago, and I think it was a Similac sensitive stomach or something like that, like a sensitive one for kiddos. I picked it. I was like, I'm just gonna look at this. So I pick it up and I turn around, and literally the first ingredient is corn syrup. And I thought, well, no wonder.
So I'll never forget. I'm in the hospital, brand new parent, obviously doing the whole breastfeeding thing. They bring in here just in case, right? Here's your emergency sensitive Similac. Turn it over. Look at the first ingredient, like high fructose corn syrup is the first ingredient.
Wild.
It's wild. Yeah. Did you know that in the US, it is illegal to make infant formula without seed oils?
I did not know that.
So that's why there's this big craze of a black market of getting infant formulas from Europe.
Yeah. Because
they're actually used with other fats per se.
Yeah.
And not seed oils. Because I don't know what government regulatory agency it was, but when they set what you had to have percentage wise to match breast milk, they would only allow seed oils to be the fat component of that. So you cannot get a seed oil free formula in the US.
Yeah. I mean, I put together a preferred formula list at our office a while ago, and I went through and I was doing a bunch of research on this stuff. And it's funny because every single formula I put on that list has to be imported, because I was going through all the US formulas. I'm like, man, these are freaking dog crap. Like it's well, it doesn't surprise me because it's just like anything else. It's super unregulated here. And, I don't know. It's such it can be a charged situation because either some moms just generally don't want to breastfeed and then other ones really can't.
Yeah.
And there's ways to go about that. There's donor milk. There's other stuff that you can do about that. And, but the formulas, man, kids on formula just struggle more. I mean, that's a fact. I don't really care how people want to look at it or not. I'm not saying that you're wrong if you're giving your child formula or anything like that. Those kids struggle more. There's a lot more for their body to process and a lot more things that are not natural to me and you as 30-year-olds, and most certainly not natural to a 1-day-old or a 3-hour-old baby. So you start giving them all this stuff, and then they start having all sorts of issues and skin and allergies and this and that and the other. Then we start wondering like, oh, I wonder why they're struggling.
Well, it's hard to navigate it. You know what I mean?
It is.
As a new parent, you're dealing with enough.
Yeah, absolutely.
And not to mention the education on this kind of stuff. Like, it's just what you think you're supposed to do. And there's not always great options on how to get around it. Like the fact of the formula, right? You can't, and not to mention the formula that we use for our son in kind of emergency type situations.
Yeah.
I can't remember the exact price of it, but it was not cheap.
No.
Like I remember the day that like we didn't buy it anymore because he didn't really need to like supplement with it at all. And I was like, my God, like it would have been cheaper just to buy like him food at the grocery store. Like that's how expensive it was.
Yeah.
I was like, thank goodness.
Well, I mean, I think it's, going back to kind of what you're saying a second, like, and I'm saying you're not wrong for doing formula. Like it's definitely kids in the NICU need formula so they can gain weight, get back to birth weight, right? There's a lot of uses for it. I think I get more upset of just like, how is it legal? There should be formula. I agree. I think it's an awesome technology, really, if you think about it. However, why is it legal for there only to be seed oils as a fat, a very unnatural thing for our body to process? And then we're literally giving that to our little babies.
It's how you're starting your GI tract, your gut flora.
Yeah.
It's what you're feeding yourself to basically to make. I mean, I remember a stat when I was in the hospital, I was looking up like calories. By the way, you don't have any kids yet, correct?
Not yet.
There's a lot of time you spend in the hospital where you're like Googling every 3 minutes. It's like, am I going to survive? Is the baby going to survive? Is my wife? So I remember I was looking up, my wife was like, you need to like Google how much like he should be feeding. Like, is it every 20 minutes, every 12 minutes, every 45 minutes? And I remember seeing the stat that a baby in the first, I think 3 months of life, the caloric intake is like you and I eating like 55 cheeseburgers from McDonald's per meal.
Yeah.
Not per day, per meal.
Yeah.
It's crazy the caloric need for that, which is awesome. What's the youngest, I mean, even going into like premature, what's the youngest infant you've worked on? How many weeks?
Yeah, it's crazy actually. Hours.
Hours? How premature though? Like, have you worked on any babies that are like mom delivered at like 20 weeks versus 40 full term?
Yeah. I've been fortunate over the last couple of years to see a lot of babies that were born premature. Earliest one was 23 weeks. Had a lot of babies that were delivered in the 20 weeks somewhere, usually late 20 weeks, 26, 28, 29 weeks. And then a ton of babies that were delivered, at 34 to 36 weeks, which is technically premature. But, usually they spend a couple of days in the NICU for monitoring and they can go home. I think in the early 20s is the earliest, like the most premature that I've seen a baby. Like, obviously they're not in my office when they're 23 weeks. But after they get usually a really long stay in the NICU, I've gotten to see them after that.
Have you ever been asked to come to the hospital?
I have.
You have? Do you do that?
I do.
You do?
Yeah.
I love it. Yeah. That's fantastic.
I just was actually seeing a baby that was in I was going and supporting mom while a baby was in the NICU at Children's in Dallas, actually in January and February this year.
That's fantastic.
Now I see her in the office because she's out.
That's awesome. What's your best success story?
Man, I don't know. We've got a lot. I think just, we've got so many. I've got some crazy ear infection cases. Got some crazy speech cases of kids being nonverbal coming into our office and speaking full sentences by the time they're done with their care plan. And one of my favorite ones, I think, is the ear infection case that we did a couple years ago. And we've had a ton of other successful ones. This was just, truthfully, it was the worst one that I ever saw. And I don't really want to admit this, but I had my doubts when they came in if I could help them because it was so bad. But at the same time, they're like, we've literally been everywhere. Right. We've had 3 sets of tubes. The ENT literally said they can't help us anymore and they don't want to see us anymore. So you're kind of our last shot, right? It's bottom of the 9th, 2 outs, and you're up and you need a hit home run. And I was like, well, if this is where y'all is at, hey, I'm here to serve you guys. And so this kid was coming in. He was about 3 years old when he came in to start seeing us. He had ear infections nonstop since he was about 10 months old. So for over 2 years, he had nonstop ear infections. He was to the point where he came into my office, he was literally just leaking fluid out of his ears. And that was the normal thing, right? That was the daily kind of normal thing. And about halfway through his care plan, he stopped getting ear infections. His drainage cleared up. He no longer has leaking out of his ears, and hasn't had an ear infection since. And I've been seeing that kid for 1.5 years now.
Wow.
He's on wellness care now, right? So they're coming in kind of in their own accord after their active care plan. And it was funny because I told mom, I was like, well, because she had an ENT follow-up appointment towards the end of his care plan. And I was like, well, just so you know, if you go in there and his ears look really good and you tell them that's because you saw a chiropractor, they're going to tell you that that's not true. And she was like, so she goes to the appointment and she comes back in for his next appointment with us. And she was like, we went, and she's like, I was telling everybody in the waiting room about how I took my son to the chiropractor and he has not had anything since and he's so much more healthy and blah, 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 blah. And everybody was kind of looking at me like I was crazy. And then I go into the ENT room and the ENT is like, wow, his ears look really good. What have you been doing? And she's like, we've been taking him to the chiropractor. And he was like, that doesn't work. That's not what this just happened on its own. So that's probably one of my favorite stories of it is a really, really severe case, but just a lot of other stuff too of, like I said, we had one kid coming in with ASD last summer, would literally go 3 days without sleeping. And after his first adjustment, he went home and slept 12 hours.
Wow.
Yeah. Other kids with, we had nonverbal kids come in and, we had one kid, this was actually a few months ago, was literally nonverbal, wasn't speaking. And then after his second adjustment, get off the table and was like, bye-bye. and mom like literally just lost it.
I was going to say the parents have to get emotional in this, man.
Just like full breakdown. Like those are situations I look at. I'm like, dude, I got the coolest job
That's
ever.
special.
Yeah. Like I got the coolest job ever.
Yeah. I thought I was cool helping people with lower back pain, but
yeah, you are. It is. It's all cool, man. Whatever serves you. Like that's just what serves me. If I just see people with back pain all day,
that's special. I can imagine just like now being a dad, I'm lucky enough to have a, really, really healthy kid, but yeah, I can imagine how emotional that'd be for some parents, especially like
crazy, man.
Nonverbal, and now they're speaking. Like that's
wild.
That's spectacular. Yeah. What's something, if somebody's watching this and they're like, I know the classic things that a pediatric chiropractor can help with. What's something that most people don't know that you can help with that you can actually help with?
Well, to be honest with you, a lot of people don't know kids can go to chiropractor for ear infections, sleep, digestion, all the newborn stuff. A lot of people don't even know they can take their newborn to a chiropractor. They don't think it's safe, which we obviously kind of digested that earlier and understand that it is safe. It is very effective and it is super specific. And I just think in general of understanding that you can take your kid to the chiropractor and they don't have to have back pain to go do that. And I see kids with really severe allergies, really severe ear infections, really severe sleep disorders, things like autism, ADD, ADHD. And we're not curing any of those things, right? But we're helping them find optimal. Right. We're actually helping them find optimal and to have a higher quality of life. So, if there's anything going on, and what I tell parents a lot is, right, you don't bring your kid to us because it's a life or death situation. There's obviously some cases that are way more severe than others, but it says that you as a parent, you innately know that your child's not doing as well as they should be doing. That's why people bring their kids to the chiropractor, because you take them to everywhere else first, and as a mom that innately it's not as well as it should be. And usually we're the only ones that listen and actually provide care and answers. So exactly. I think it's the biggest thing.
I love it. And this has been great. I got one last question for you. If you've listened to any of my podcasts, I named this, "What Can We Get Into?" Because, we've gotten into a lot of things. Mm-hmm. What do you get into outside of work? What keeps you ticking?
I like to work out. I like to do yard work to some extent. I'm a pretty boring guy, to be honest with you, man. I'm not like a big traveler. Like Kara's like, man, I want to travel the world and do this and do that. Like I'm a pretty boring guy, man. I like to work out. I like to hang out at home with my dogs. I like to cook a lot. Okay, I do like to cook a lot.
There you go.
Hopefully going to get a new Traeger or something like that soon. But I like to cook a lot. It's like it's one of my other creative outlets.
So you're a Traeger guy?
Yeah, I think so. Well, I say that. Okay, like I used to have offset.
You strike me as more of a manual offset guy. But yeah, okay, go ahead.
I think the flavor from an offset would be significantly better. But I mean, especially I like to smoke brisket and stuff like that. The ease of being able to go load pellets and trim your brisket and throw it on and then come back out, you're good.
There is a best of both worlds, right? Camp Chef has a pellet smoker that you can also put wood chunks in. Oh. So we have switched gears, by the way.
Yeah.
For the first, most of your smoke flavor is coming from the first couple hours.
Right.
So you can it's got a little box comes out. It's underneath the firebox. So you put in wood chunks, you put in charcoal, you put in wood chips. You can even get a decently small split in there.
Yeah.
And it will the pellets are still going.
Right.
But it's doing that on top of it. And then once you've kind of gotten enough of that on there, then you just go pellet for the rest of it.
Yeah. Okay.
Because at some point you're probably wrapping anyways.
Yeah. Yeah.
So it doesn't matter.
There's different theories there, man. If you wrap too early, you can mess up the bark. We're getting into some pretty different theory now. But I'm feeling like I'm out of the game. What'd you say?
The old Texas crutch, wrapping a brisket.
Yeah.
You like to let it go all the way through and don't touch it?
Yeah, I do. I'll wrap it usually 165, 170. If I'm going to wrap it, but I won't do it in foil. I'll do it in actual butcher paper.
Yeah.
But we moved last year and I had it was kind of ridiculous. I had a box smoker, I had a Blackstone, I had a charcoal grill, and I had a gas grill. And we were moving. I was like, dude, I got to get rid of some of this stuff. So I got rid of my smoker was old and I had just absolutely beat the heck out of it. So I got rid of my smoker. I got rid of my Blackstone. I got rid of my charcoal grill. So I just have a gas grill right now. So I've been I smoked stuff a lot.
I used to see it on Instagram, man. Is there still a channel Collin Cooks, Kara Eats?
Yeah, she still posts it to her stuff. I'm actually really not on social media. I actually deleted my Instagram off my phone 8 or 9 months ago.
Did you really?
I did. But I don't see too much of it anymore. But I know she still posts it all the time. I still cook a lot. I cook all her meals for her. I still like to cook. It's a good deal for her.
Man, I love that. I think cooking is a fantastic, creative outlet. We've been living in places that have not allowed grills, and it's it just got me chomping at the bit because I love it. It's one of my favorite things. I had a neurosurgeon on, Dr. Ferraro, a few weeks ago. Mm-hmm. And he was like, man, I was like, what's your best recipe? Because he's an Italian guy. He's talking about how he grinds his own meat and all this stuff.
Oh, wow.
And he goes, I think my best dish is a bolognese, and which is funny because that's my thing. Like I do that. If I bring you into my house the first time to like hang out, whatever, it's what I make every time. I've probably made it literally 100 times. Not even joking. And this guy goes, okay, like, let's go. I was like, how many times have you made this? He's like, I think I've made it 3 times. I'm like, bro, this is a grand slam. Like, what's your best dish?
Man, I go kind of hard on different things. I mean, it can't ever beat a steak and some good sides there. Where I go the most hard for whatever reason is Mexican food. So I have a tortilla press.
Oh, baby.
I go pretty hard on like tacos and all the stuff like that. I go pretty hard into Mexican food, and then I've done Italian stuff. I do like to make gnocchi. I like making a gnocchi in a homemade tomato sauce, and I've made homemade pasta. Man, what else? I did mess around with for whatever reason. So Kara, for our wedding, got a KitchenAid, like the classic girl thing to get for a wedding.
For whatever reason.
Yeah, right. Because she thought she was going to use it. So we've been married for, I don't know, I think going on 3 years now. Like 2 months ago, I took the KitchenAid out of the box.
Oh, no.
I always walk in the kitchen. I'm like, Kara, use your KitchenAid. My mom got it for her. So I always joke, like, my mom bought you this nice KitchenAid, and like, you're not even going to use it. Because Kara says she doesn't like to cook, she likes to bake, but she doesn't ever cook or bake anything. So I saw this croissant recipe, and I was like, I can make croissant. I'm going to make croissants. It's like a 2-day process.
I was going to say, that is not.
They turned out okay. But anyways, I got her KitchenAid out and just put it to work on those croissants. I don't know. I do a bunch of different stuff, but like, and I'm like go-to stuff. It's like, man, I'm probably going to throw down on some form of a steak, rack of lamb, something like that, with some good sides. And then, or I'm going to go hard on some tacos and like I get really creative with tacos about how I want to go about that. So I make different tortillas. I have a tortilla press, all that. That's awesome. Stuff.
That's really cool. You threw me off with that, the KitchenAid thing. Cause we kind of had the same thing. The cool thing about the KitchenAid is you can get a pasta
maker. Yeah. I haven't done that.
Have you done that yet?
I like cut it. And it never turns out, the shape never turns out perfect. I'm like, Kara, we need to get the pasta attachment for the KitchenAid.
Yeah. No, it's a game changer. Yeah. I think that making your own pastas, it's a game changer for pasta. It is for sure. For sure. Yeah. It's a lot of work. Man, thanks for coming on.
Absolutely, man.
It's been awesome. I had you on a little bit for myself to learn, and I think people are going to love this. So
cool.
Thanks for coming on, man.
Absolutely.
Where can people find you?
I am at Social House Chiropractic in Prosper, Texas. So you can see me or find me at Social House Chiropractic on Facebook or Instagram. I have a personal social media as well. I'm Collin Walding. It's pretty straightforward there. But yeah, I'm pretty quiet guy, but I am online. I'm just not there too much.
I love it. If you need a pediatric chiropractor in North Dallas, he's your guy, him and his wife. Awesome. Yeah. Thanks for coming on, man.
Absolutely,
Appreciate
man.
you.
Absolutely.